Hi guys, it's Julie and Sabir and Doc over here at Pro To Col Systems, and today we are coming to you because I notice a lot, and I'm sure you guys do too when you're out, there's a lot of people who are injured in the gym who don't necessarily know that they're injured and or are going to people who might not necessarily know how to assess their injury so much. I've been at the gym a lot of times when people are hurt and they're hurting in the shoulder or they're hurting in the knee and they can't even raise their arm above their head and they go to their janking on them. And there's so many avenues to shoulder injury. I want everybody to have an opportunity to, if you find somebody that does have an injury, you can properly assess them or have some kind of an understanding of what to do and when to refer out. So I am going to pass it over to Doc, who's going to use Sabir as our lovely model, and we are going to show you the different avenues of the shoulder anatomy and impingement and different types of injury.
Yeah, so I'm Dr. Bates, sports medicine and family medicine, and just to sort of parrot what's already been said, with the shoulder injury, if you're suspecting that you have a shoulder injury or you think there is a shoulder injury, it's really important not to make it worse. So what we'll cover today is some of the things that are seen most commonly, and these can be treated as well. It's just a matter of giving the correct diagnosis. So let's go over a little bit of the anatomy first. I have a marking pen here, so to make things a little bit easier to see as well. So when you look at the shoulder, what's important to do is look at both of the shoulders so you can compare, and oftentimes you have the shirt off. So you can look from the front, you can also look from the back. When we're looking at the front, what you want to notice is what the clavicles, what the collarbones, if that looks even, if there's any protrusion or depression, and then how those clavicles ride out to what's called the acromion, okay? And this joint here, this is usually called the highest part of the shoulder. This is the AC joint. So this AC joint here will actually, can be a major source of pain. And what's unique about it is even though it's very small, it's about the size of a dime, any motion that you have with your shoulder, whether you're raising your arm to the side, forward, reaching back, the AC joint is involved. So if we're to just draw out the clavicle, so I'm just going along the clavicle here just so that you can actually see it. It has a little bit of a curve to it. And where this is going to take us is all the way back here till we get to what is considered the acromion. Okay, so the acromion, there's lots of different names for different structures for the shoulder, and not to get bogged down in the nomenclature, but this is the clavicle. This area here is the acromion. And what I want you to get from that is the acromion is attached to the scapula or the shoulder blade. And if we are to take Sabir's humerus here, and this is the acromion makes a roof over the humeral head. And so when you raise your arm, if he raises his arm up, what's happening is the humeral head is rotating, and he gets to a place where he can't raise his arm anymore because literally bone is connecting to a bone. So that brings up the first concept of something called an impingement. So I should be able to take his arm and bring it up over his head. He should be able to take his arm and bring it up over his head without any pain. There's no pain here because the rotator cuff is not getting pinched, and the bursa, which is a sac just above the rotator cuff, is also not getting pinched. So again, if we take this acromion, which is the roof, and the humeral head, you see the space that's here. Inside of the space, the rotator cuff needs to travel through that space. and the bursa, which is a fluid-filled sac that makes sure there's not too much friction going on inside of the joint, that is there to protect the rotator cuff. So impingement would be, he raises his arm, bam, there's pain right there. Usually a sharp pain, something that makes a person stop, and usually makes them say, ouch. You don't want to crank the arm and bring it past that point of pain. You don't want them to be doing exercises that are beyond that point of pain. Oftentimes what happens is the person does something beyond what they normally would do. Maybe you're working with someone that doesn't work out a lot and they move their entire house. Or maybe they painted 2 rooms and they did the ceiling. They did a lot of overhead work. They inflamed the bursa, the fluid-filled sac, and that bursa is trying to protect the shoulder for a few days. Let's say that they popped some ibuprofen or Motrin and they just ignored the pain. They powered through. They're like, we got to get this room painted. We only have 1 more day. Now what happens is when you're bringing your arm up, the bone is connecting to bone. Now you're actually not only pinching the bursa, now you're starting to get to the rotator cuff. So this is where you can fray your rotator cuff. You can create a hole in the rotator cuff. You can tear the rotator cuff. And so this is another reason why you don't want to crank and make someone move through a range of motion if it's super painful for them. So this is one of the tests. This is called nears. So you're basically just bringing the arm near the ear. That's how I remember it. Another one is called Hawkins, and this is something you can do. You bring the elbow out to the side. You hold the elbow like such, and then you're going to rotate the person's arm like this. So what this is doing, in a way, you can kind of imagine a wing. So this is called Hawkins, hawk, a wing, and what you're doing is bringing the humeral head up to the acromion, and you're basically banging the humeral head against the acromion. So those are 2 different things.
Yeah.
Right.
So let me ask you this: if somebody is assessing their client and they come up and there's pain when they do it, but when you do it, there's no pain, what's the difference?
So the shoulder has a lot of different overlapping structures that occur in the same area. It could be that what's happening is when the person moves and then they have a certain amount of pain, they're activating something in their shoulder that is generating pain. Whereas when I move their shoulder, they're not having to work, they're not activating certain muscles or certain structures so that there isn't pain. It's there.
Okay. And then when should the trainer or the therapist actually refer out? Like, when is it like a no-fly zone where you're just like, uh-oh, we've reached a point of no return here, I can't do anything, I need to send you to somebody else?
Yeah, so with the shoulder, if the pain is getting worse, you should refer them out. If, let's say you've been working with them and it's been several weeks to a month and there's no alleviation, they're just kind of stuck right where they are, then you should refer them out. Part of what's really important about that is you don't want the person to lose their range of motion. When you start losing your range of motion in the shoulder, it takes a long time to get it back. It takes a lot of work to get it back. So you want to be able to preserve that range of motion as best as possible as you're helping them through. So those are two times.
And what I found, though, also is a lot of times, especially, no offense, guys, we're working with the jiu-jitsu community, I see a lot of this. So everything is flexed. So get in. I think this is like the ideal candidate that we see. And so if you're sitting like this and everything is anterior and medial, Sabir, being anterior and medial, can you actually raise your arms all the way up over your head? It's almost impossible. So a lot of this range of motion, they may have limited range of motion, but it actually might be coming from their back, from their thoracic spine, not being able to actually get an extension, and or this big shoulder blade that needs to come into play too. I mean, everything needs to be in working order for us to actually bring our arm up over our head. So we have actual injury that's happening, and then we have like a motor control and stability issue where we might just have no ability to actually bring our arms up over our heads because of the way that we've been playing for so long, or working for so long, or sitting for so long. A lot of the teenagers these days, this is their position. Everything is here. And if you see them, their whole back is in such flexion. that they actually cannot sit up straight after a while. It just gets compounded. So I think there's a few different things to look out for. Some that are true injuries that you get to do. Now, if Sabir comes in and he's like this and he can't raise his arm, don't do this, because you're not going to make the arm actually go into extension by just using the glenohumeral joint. You need to actually think about going into the back and all of the other parts that go into it. Don't you think?
Yeah, absolutely.
Yeah, there's so much that goes into different types of injury. It's really about taking a look at the person as a whole and paying attention to the entire person on how are their shoulders, where is their chest, where is their back, is everything moving? If they raise their arm up and down, does their shoulder blade actually go up and down, and upwards and downwards rotation, and elevate and depress? You need all of those rotations and actually to make your arm work properly. Otherwise, you're asking for other parts to come in and help out, and then you're going to end up with more injury, like bicep or something else that gets to get jumped in. So that's a big part of the shoulder anatomy. Now, I want to jump into really quickly, while we have time, I want to jump in. We actually had somebody come in this morning who had a lot of knee pain, and she was coming in, had no idea why. We assessed her, we kind of moved her, but she was always having all of this knee pain on either side, and she had no idea why. So it turned out that Doc ended up examining her. I did an assessment, couldn't find anything, and then Doc examined her, and it was her popliteal tendon, or popliteus, which is a muscle that goes alongside the back end of the knee. There's a lot of different types of knee injury as well. It's really, really common. So I wanted Doc to touch on the knee while we had time.
Can we answer a question really quick?
Sure.
So Danielle wants to know, how do you feel about postural support braces?
Oh, and I think those are those braces that are essentially bringing your shoulders back. When people have had a clavicular fracture, they've broken their clavicle, depending on the type of fracture, you can use those in order to help the person bring their shoulders back. I think those can be helpful as far as cueing you to correct your posture, but in the long run, what you have to do is you have to actually work on the muscles in order to strengthen these areas that are in the upper part of the neck and the mid part of the back, and then allow these areas that have been overworked to stretch and to open your chest. So it's not a quick fix, but it is something that can help cue you in order to sit up straight, and when you're at your desk, bring your shoulders back.
Got it.
Right. And one of the things that we do here is postural correction. So once we actually take you through all of this at Pro To Col, we'll actually put you in through functional movement and postural correction to really teach you how to control your own body, so that when this happens to you, it feels actually very foreign instead of common. So we'll make sure that you get to take this on as your own and really use it and feel the muscles activating and working. So, do you want to move on to the knee?
Yeah, let's talk about the knee.
Perfect.
So, can we see a little leg, please? Thank you. So, with the knee, any athlete has had some injury with the knee at some point or other. I like to think of the knee as like a chair. A chair has 4 legs, and like a chair or a room with 4 walls, everything needs to be stable in order for that chair or that room to work appropriately. So the 4 basic ligaments in the knee are going to be your MCL, which runs the inside of the knee. MCL stands for medial collateral ligament. The LCL, which is the lateral collateral ligament. And then inside you have your ACL and your PCL. And a lot of people have heard about ACL injuries because of how devastating they can be. And then inside of the knee, acting as cushions, you have your meniscus. So that can be another source of pain. It can be another source of injury as well. With the knee is if you feel a pop, if you have pain after that pop or swelling, that's a time where you need to chill out for a little bit, let things calm down, and if the pain persists, then you need to be seen in order to really get the proper diagnosis. What was interesting today, seeing and treating a few folks that had knee injuries, was this particular muscle called the popliteus, which is the belly of it, is right here. When I examine a knee and I touch a knee, certain areas should not be tender. So when this area here, just underneath this flare, kind of goes in here, this belly of the muscle, it wraps around the knee, and then it ends up inserting right in the joint line area here. And so that muscle, what I've seen consistently is when someone's had a knee injury, this muscle can get strained and it can just be a source of pain itself. Another injury that's really common is the MCL, and lots of people have injured their MCL. Sometimes it comes with meniscal injury as well. The MCL is a really thick and broad ligament, and it provides a lot of stability to the knee. So when the MCL gets injured, if it doesn't heal appropriately, it can actually make it so that going up and down stairs can be difficult. Twisting motions or having pressure put on your knee can be difficult in this direction here. And so coming in and getting that treated can make a huge difference in your performance, can help you with your sleep if your leg's been bothering when you sleep. With running, any kind of cutting motion, getting this treated can be really, really helpful.
Yeah, I will say there's a couple of other things with the knee where it can present like a knee injury, but it's actually either in the tibia, the ankle, or in the hip joint. So a lot of times, the knee, it flexes and extends, rotates a little bit, flexes and extends, right? So there's this relationship between stable and mobile joints. And the knee is a very stable joint. The ankle is a mobile joint, and the hip is a mobile joint. So a lot of times through either an ankle injury, or where they put you in a boot, or they put you in something, or a hip injury, or the way that we stand or what we do, we tend to lose mobility in either the ankle or the hip, and then we're asking the knee to create the mobility for it. So a lot of times this poor knee, which only is supposed to do one through fluid range of motion, is asked to do a whole lot, and then it'll start creating a lot of symptoms that may present similar to your MCL, your LCL kind of strains or tears. So for a lot of people, when you're looking at it, you may want to look at the ankle and you may want to look at the hip. You want to make sure that the tibia actually rotates. You want to lay down for me real quick? So we're going to go to this leg now. So if I'm looking, first of all, I want to see that he's got full dorsiflexion, his ankle. I want inversion and eversion. So this is dorsiflexion, this is plantar flexion. And then if I'm looking at the knee, I'm taking his tibia and I'm trying to see if his tibia actually moves. So as we step down when we're walking, as we transfer our movement, as we push down off the foot, the tibia rolls, and then the femur rolls. And then as we pick our leg up, the femur rolls, and then the tibia rolls. So it's like where everything's going medial, and then everything's going lateral. Does that make sense? So if you're not having movement in here, where the tibia is actually either laterally, there's a torsion where it's laterally stuck into the femur, or the hip joint in the hip capsule doesn't have fluid movement, what it's going to do is it's going to create the movement out of the hip. Mm-hmm. Does that make sense?
That would be more stress.
Yeah, it's a lot more stress. And so sometimes it'll actually even present, I've even seen it as like a meniscal issue, where people come in and say, I think I tore my meniscus, and it turns out that it's really unlocking the hip and the tibia, keep getting the torsion out of it, and the ankle, and then this goes away. Mm-hmm. So that's another thing to look at. Just a couple of tips on the way.
Yeah.
Got anything else?
Yeah, I did want to cover one other aspect, if you could sit up real quick. Sometimes you'll have folks come in and, oftentimes they'll be able to point to where the shoulder pain is. And it's a good idea to have them point with one finger, where's that pain? So when it's in the anterior, the front part of the shoulder, or the very side, then, those structures you can isolate. When it tends to be the back of the shoulder, this is where you need to start thinking about what's the joint above, and that's going to be his neck. So sometimes people will have shoulder pain, but the origin of the pain is because it's in the neck. So I just want to show you a way of assessing that. So let's say they say, I get this sharp pain in the back of my shoulder, but it only happens when I do some funky kind of motion, and they can't really reproduce it. There's a couple things you can do. One is just pressing down on the head here, okay? What we're doing is compressing the spine. Those nerve roots that come out through the spine, we're actually putting a little bit of pressure on those nerve roots. So if we press down and they say, wow, that really that hurts, like that's where it hurts, you know it's coming from the neck, most likely, okay? Let's say you do that and they're like, nothing. Then what you can do is tilt their head back, turn it slightly to the side. So I brought the head back, I'm turning it slightly to the side, and now I'm gonna press straight down again. And if that reproduces the pain, again, most likely it's because it's coming from the nerve roots that are in the neck. So regardless of what you're doing in the shoulder, it's not going to do anything because the pain is coming from the neck. They may have a shoulder injury as well, but the pain, one of the pain patterns that they're feeling is coming from the neck. So that's something that's really important. It gets missed a lot because we just tend to focus just on the shoulder, whereas we need to check out the neck as well.
Yeah. So there you go, guys. There's a couple of tips. Hopefully it helps. We're here all the time, Pro To Col Sports Systems. We are the pros in the know, and we're the pro tip of the week. We do postural correction, functional movement. We do sports med, injury prevention.
Prolotherapy. Platelet-rich plasma.
Mm-hmm. Yeah, stem cell. We do a little bit of everything here. Chiropractic, we've got it all. So if you're interested, please leave your comments down below. Or if you have any questions or comments, and we will for sure answer them. And we will see you again next time. Have a great day.
All right, bye-bye.